is from Srinagar. He is the Vice Chair of MENA ISN Influenza Stakeholders Network. He is the Editor-in-Chief of Lung India.
A very good afternoon to all of you. First of all, I'd like to apologize for not being there in person due to an unscheduled travel that I had to take, and that necessitated my being away from the meeting. Thanks to Dr. Christopher, Dr. Vijay Hadda, and the organizing team for inviting me to talk on thoracic sarcoidosis treatment and the challenges that we face while treating patients with sarcoidosis. I'm sure Dr. Sajal must have taken you through all the algorithms of investigating a patient with thoracic sarcoidosis. And I'm going to embark only on the and most of my my talk would be based on the ERS BTS guidelines that came in 2021, and a perspective that has been scripted by my previous speaker, Dr. Sajal Dhuria, who I regard as one of the brightest in the field. And he is going. He has written a perspective which will be to your hands available on the 31st of October. And he has been kind enough to let me use some of the quotes and figures from his talk, from his manuscript. So the outline of my talk would be to find out as to whether once we have diagnosed a patient with pulmonary sarcoid, whether we have to treat everybody, when to initiate treatment, what should be the duration of treatment, what are the times when we require to change treatment, how to treat a relapse, and various other challenges. And we'll also talk briefly about the recently completed and ongoing trials. Sarcoidosis we know as a tightly packed, non-caseating granuloma consisting of various mononuclear histiocytes, epithelial cells, multinucleated giant cells, and some degree of fibrosis. And generally, non-caseating can have evidence of necrosis in 10 to 14% of cases. And the development of the granuloma is brought about by involvement of a number of cells which react to an undetected environmental antigen or a microbial antigen or an autoimmune phenomenon. Number of cells are involved, generally the monocytes, T helper lymphocytes. They cause recruitment and proliferation of the cells to the particular area of inflammation, which leads to the development of the granuloma. And this granuloma can lead to alveolites in case of the pulmonary sarcoidosis, and this can stay as a non-progressive granuloma, can stay silent, or can resolve over time, or it may evolve into fibrosis. So do we need to treat everybody who has been diagnosed by the EBUS that Dr. Sajal must have spoken to you about with or for a mediastinal lymphadenopathy? Do we need to treat everybody? The answer is an emphatic no. The aim of therapy for sarcoidosis in the thorax is to minimize the risk of disability, which means that you've got to reduce the organ dysfunction or reduce the quality of, improve the quality of life. If there is a loss of quality of life, somebody has an incessant coughing, somebody has fever or arthralgia, those have got to be taken care of. We have to balance this treatment against the risk of comorbidities and loss of life as a loss of quality of life as a result of the therapy itself, because the therapy that we give, primarily, for example, glucocorticoids, have a number of side effects on many systems of the body, and we have to balance the harm versus the risk. And it will be prudent to say that interstitial lung disease and pulmonary hypertension are the main causes of mortality and lifetime poor exercise tolerance. So it affects the survival as well as the quality of life in patients with sarcoidosis. Who is having a high-risk pulmonary sarcoidosis? Patients who have evidence of lung function decline in the form of reduced FVC percent predicted or DL2 reduction. Those who have moderate to severe pulmonary fibrosis on imaging of the chest, or those who have precapillary pulmonary hypertension. The loss of quality of life generally occurs because of dyspnea, chest pain, cough, and variably because of other symptoms like malaise, fatigue, and arthritis. Diagnosis, as I already said, does not merit treatment. every time, and acanthoma formation can be a reaction to an antigenic insult, and if the patient is not symptomatic or has no evidence of a possible progression or on investigation like radiological imaging, we better not fiddle with the patient. General treatment goals are to achieve either disease regression or short-term disease stabilization when the disease is irreversible in nature. With higher dose glucocorticoid treatment and in those states, and to identify the minimal dose that is required for stabilization. And I say it again, weigh benefits. We know about the scanning grouping from 0 to group 4 depending on the involvement of the lungs on radiology. They have stood the test of time. Stage 1 and stage 2 may not be associated with any lung function abnormalities and can remit or resolve without treatment. So you have to take a very careful decision in these patients, if at all, whether to treat them or not. However, stage 2, stage 3 and stage 4 can affect lung function and generally require treatment. Lung disease with significant radiological burden, which may not be present symptomatically. There may be no symptoms, but there is significant radiological burden, does affect your decision, and you might require to treat the patient. And whenever we embark on treating the patient, we have to assess the severity of the disease itself, the pulmonary disease, and also try to figure out if there is an involvement of any other organ system, which is very routine in patients with sarcoidosis, because sarcoid is a multi-system disease. So we get a chest radiology, mainly in the form of a CT these days, which provides static images of structural disease. We get a hybrid PET scan, which provides the structural and functional lung assessment. Pulmonary function has got to be assessed both by spirometry and DLCO and the 6-minute walk distance, because there will be many cases who may have an isolated DLCO abnormality without any definite evidence of a restriction or obstruction. So DLCO has got to be done. We get an idea of the other system involvement by getting the CBC and the blood chemistry, serum calcium, urinary calcium, liver function and kidney function have got to be done because they can be involved. Ocular examination, ultrasound, abdomen and fibroscan can be required to assess the liver and the eyes. We need to assess for cardiac sarcoid by an ECG and echo and a cardiac MR of the PET scan. 24-hour Holter might be required if there is evidence of dysrhythmia. Echo right heart catheterization may be required in patients who have cardiac sarcoid or pulmonary hypertension. And we must also investigate patients with various appropriate investigations that are relevant for the organ system that we suspect involvement of clinically, be it skin, be it joints, or the kidneys. So what are the criteria for treatment in pulmonary sarcoidosis? If the patient has pulmonary function abnormalities, FEV1, FVC or FEV1, FVC ratio of less than 70%, or there's a fall by 10% due to sarcoid. If the patient has a DLCO less than 60% or a fall of 15% due to progression of disease, and a high radiological burden that clinician believes would result in significant fibrosis. For example, there is a peribronchiovascular thickening involving more than half of the lung field. So how to initiate treatment? If the aim is to improve the quality of life, use minimum doses effective for improvement. And if the organ dysfunction has got to be tackled, we give upfront aggressive and prolonged therapy to reduce organ dysfunction. For life-threatening situations, the dictum is hit hard, hit early. If organ dysfunction is slow and protracted, we might require to give less intense immunosuppression for a prolonged period of time. And the agents that we use generally are the glucocorticoids in equipotent doses, prednisone, methylprednisolone, deflazacort. Low doses have been found in recent studies to be as good as high doses. Methotrexate is a usual second-line agent, but is being tested as a first-line agent along with or without steroids in the PREDMET trial. Small doses effective must be used for improving quality of life. For example, a patient has an recurrent incessant cough, you've got to go to the lowest dose required. So these recommendations, these are the ERS task force systematic review of literature. They selected 19 studies out of a potential 1700 plus potential articles, and they found that the overall response of oral glucocorticoid treatment based on clinical and radiological evaluation of 2 studies found a larger proportion of patients experiencing clinical improvement, a risk ratio of 2.4 in short-term follow-up. And there was also a trend for fewer patients experiencing clinical deterioration in the short term. Radiographic improvements favored glucocorticoid treatment with a lower prevalence of significant radiological deterioration. Pulmonary function was, however, not significantly impacted for the whole group. However, those patients who had significant pulmonary dysfunction and lung involvement at the stage of start of initiating therapy did register an improvement. A Gibson study way back in 1996, published in the Thoracic, reported that asymptomatic patients without radiographic improvement were randomly allocated to receive either glucocorticoids for 18 months or corticoids only if patient worsened clinically. At 5 years, the treated group had better functional outcomes. So there is no existing controlled evaluation of glucocorticoid treatment efficacy in preventing pulmonary function decline in severe pulmonary disease. The protocol would be that if a quality of life improvement is the goal, we use a small dose of 10 milligrams. This is also used for managing extrapulmonary symptoms like fever, arthralgias, and fatigue. If organ dysfunction is something that is targeted, we start with a higher dose of 20 milligrams. Some use even higher dose of 30 to 40 milligrams initially for rapid response to the symptoms, or improving an attendant extrapulmonary symptom like hypercalcemia. For a life-threatening extrapulmonary sarcoid, also we might use even higher doses. 40 to 60 milligrams have been used. We use a second-line agent. It can be used upfront to reduce the dose of steroids quickly. Give 20 milligrams for 2 months, followed by 15 milligrams daily for 2 months, and always watch for drug side effects. How long do we treat? If the treatment is started for quality of life, 8 to 12 weeks of therapy may be enough. We got to taper it by 2 to 5 milligrams every 3 to 4 weeks subsequently. For organ dysfunctions, the duration has got to be 6 months in most of the cases. We, in the recent Sarco trial, 45% had a failure or relapse at 6 months, suggesting that a prolonged therapy for up to 1 year may help. We have to monitor patients clinically, functionally, as well as by imaging, and taper the drugs slowly, monitoring the clinical, physiological, and radiological changes. And if tapering leads to worsening, treatment might require to be prolonged for as long as 2 years. This is one of the studies from All India Institute of Medical Sciences looking at the extent of disease activity and response to treatment once PET-CT was used as the monitoring tool. And you can see that in this patient he has evidence of FDG active disease, which has regressed largely by the treatment. And whereas in this patient there has been no appreciable reduction in the disease. What are the add-on treatment, the second line, third line agents? When there is a poor response to treatment, intolerance to the drugs, that is glucocorticoids, or perceived adverse side effects, or patients who have more than 10 milligrams for disease control after 6 months of therapy, that's the time that we think of using additional agents, second-line agents. And we know for sure that higher doses are less tolerated, and the agents used can be methotrexate, leflunomide, azathioprine, or mycophenolate. If even after introducing these second-line agents there is evidence of ongoing inflammation driving a poor response, we may use third-line agents like rituximab, infliximab, or repository cosentropin injection, or even JAK inhibitors. The summary of evidence for this, as given by Wolfman and his colleagues in the ARS clinical practice guidelines, 6 studies were included out of 1300 plus that was initially looked at. 6 drugs were studied, ranging from methotrexate to infliximab and cyclosporine. In one randomized controlled trial, which was double-blind and placebo-controlled, methotrexate did not demonstrate significant efficacy improvement, although it allowed a significant prednisone reduction and lower weight gain at second 6 months. And open-label prospective and retrospective trials have found methotrexate to be steroid-sparing and associated with improved lung function. Infliximab, which is an anti-TNF antibody, compared to prednisone, significantly improved FVC, which was the primary endpoint in 2 phase 3 randomized trials for treatment of chronic respiratory symptoms. However, there were not appreciable changes in FVC. No recommendation was made by the ERS for cyclosporin A or newer monoclonal antibodies, as randomized trials did not show any benefit for placebo. Again, continuing with the summary of evidence by the ERS group, azathioprine was found to be as effective as methotrexate in pulmonary sarcoidosis. Leflunomide and mycophenolate are also effective. In randomized controlled trials, chloroquine was mildly beneficial in pulmonary sarcoidosis. In a retrospective study from one center, chloroquine was less effective than in pulmonary sarcoid than in skin sarcoidosis. Adalimumab was found to be effective in pulmonary disease in one prospective open-label trial and small retrospective series. We give methotrexate in the form of 15 mg weekly with folate supplementation. We can increase it after 6 months. Taper slowly by 2.5 to 5 milligrams every 6 months in case of a response. Alternatives to methotrexate, we know that we can use azathioprine 50 mg, increase by 25 to 50 mg every 2 to 4 weeks till we reach a dose of 2 milligrams per kg body weight. If the disease is not responding, introduce third-line agent like infliximab or adalimumab. How do we manage relapse, which is another challenge that we face? Whenever there is a significant worsening in symptoms, organ function, or imaging during treatment or within 12 weeks of stopping treatment, it is termed as a treatment failure. Anything beyond 12 weeks would be considered as a relapse. So we might have to reintroduce glucocorticoids, introduce second-line drugs at first relapse is the mantra now, which used to be introducing the second-line drugs at second relapse previously. Long-term treatment for relapsing disease might be required. So, suggested protocol by Sajal is that we treat with prednisone for 2 weeks, followed by 15 milligrams per day for 2 weeks, 10 milligrams per day for 4 weeks. Thereafter, taper to 5 milligrams for 8 to 16 weeks and 2.5 milligrams for 2 to 8 weeks. In addition, a second-line agent, methotrexate or azathioprine, should be started. Treat patients with relapsing disease for 2 years or more. There are a number of challenges with drug trials and drug development in sarcoidosis. So we have a problem in careful definition of the target cohort, because a single organ may be involved, multiple organs might be involved, and we have to try to make them uniform as much as possible. We also need to promote diversity and ensure equitable enrollment of minorities and non-white participants. Despite the fact that sarcoidosis is more common in blacks and is more severe with more complications in blacks, their enrollment in studies has been minuscule. That is because of a mistrust in the system, a lack of interest in clinical trials, fear and stigma associated with participation, and a perception that blacks may not be compliant with trial protocols, biased by the investigators. So these have got to be taken care of, and unfortunately endpoints in sarcoidosis trials are not clearly defined. These are some of the potential endpoints that have been proposed in a recent review in Frontiers. One is by physician judgment, clinical judgment and improvement, worsening or progression, steroid sparing as to what would be the percentage reduction in steroid dose, cumulative steroid dose, duration of time at minimal dose, radiological or evidence of activity may be by CT or PET chest imaging, medication toxicity, serious adverse effects, life-threatening adverse effects or adverse effects leading to discontinuation of the therapy. Pulmonary functions by spirometry, DLCO and CPI, exercise capacity by 6-minute walk distance, health-related quality of life by various standardized scoring systems, and mortality, though mortality often not feasible, but the composite outcome can be studied. Another issue is the subject retention, which in clinical trials, which basically relies on principles of patient safety, comfort, and anticipating medication tolerability and cost of participation. It necessitates incorporation of preventive measures and management of toxicities related to the drugs that we give. For example, in case of steroids, ensure gastric, bone, endocrine, and cardiovascular protection, as well as measures to address psychiatric and sleep disturbances that follow any available published guideline for prolonged steroid use. There's got to be a fair reimbursement for participation, because they may not have access to care. They're generally of a lower socioeconomic status, so they lose work, and that has got to be recompensed for once they are actually involved in a clinical trial. Other measures also have got to be introduced, like pulmonary rehabilitation, taking care of osteoporosis that ensues because of the steroid use. We might use H2 blockers or proton pump inhibitors to treat dyspepsia. Vaccination is routine now for pneumococcal and influenza vaccination, and currently there is a lot of emphasis on herpes zoster vaccination as well. Talking about recent ongoing trials in pulmonary sarcoidosis, there has been a trial on anti-IL-18, one on anti-GM-CSF, and we know that there has been a lot of interest in the transfer RNA synthesis drug, that efzofitimod, in patients with pulmonary sarcoidosis, as also in other interstitial lung diseases. The PREDIMET trial looks at the effectiveness of methotrexate versus prednisone as first-line therapy for pulmonary sarcoidosis. QUID-POSE looking at the efficacy of hydroxychloroquine with low-dose corticosteroid. And SARCOD, as I talked about, was 2 doses of glucocorticoid regimes, and 40 milligram has not been found to be superior to 20 milligrams. An interesting study has demonstrated there was a clinically significant improvement in FVC and a trend to improvement in fatigue scores by giving nicotine to patients with pulmonary sarcoidosis. However, there was no change in health-related quality of life scores or in the radiographic burden of disease. Nicotine was found to be non-addictive in this study. However, this was a small study, and we need to ratify these results by a large trial. There was another phase 2 investigation of antimicrobial agents, clear drugs therapy on progressive pulmonary sarcoidosis. Though there was a significant decline in ESAT6 immune responses, there was no corresponding reduction in FVC or 6-minute walk distance at the end of 16 weeks. Other successfully completed trials have included those targeting the anti-IL-1 monoclonal and anti-IL-1, another is a repository syntropin, with the prolonged release adrenocorticotropic hormone ACTH and other peptides, which has a complex multi-mechanistic action in sarcoidosis that is distinct from routine steroids, and studies have found that RCA can help steroid sparing. Phase 1 proof of concept study evaluating the role of tofastin has been tried, and addition probably was a small study and did help patients with steroid refractory pulmonary sarcoidosis to taper their steroids to the 5 milligrams. This is the ERS guideline. They have divided patients into low risk, intermediate risk with impaired quality of life, and high risk. Low risk is got to be observed. We have to assess the need for treatment, and whenever it is required, we give glucocorticoids alone. However, when the patient has an intermediate risk but has impaired quality of life, we give the lowest possible dose of glucocorticoids. If there are significant glucocorticoid side effects or a continued disease or a relapse, we add second line and then third line agents in that order. We can use infliximab, adalimumab, rituximab, JAK inhibitors, or repository cosintropin injection. And the similar schema is followed in high-risk patients. Every time we look for significant glucocorticoid effects, continued disease, or relapse, and take a decision as to whether to continue therapy or try to get a successful GC. Many times we need to send these patients for lung transplantation, and that time the survival has been studied. It is similar to that of patients with sickle cell. There are a number of unmet needs in sarcoid, and we need to focus on them. These were the ones that have been given by the ERS BTS guidelines. There is a need for accurate risk stratification. We have to have optimal pulmonary function thresholds integrated with disease duration and risk assessment for progression in high risk disease. We need to find out if high-risk disease is best managed with glucocorticoid monotherapy or combination therapy with second-line or third-line agents upfront. The role of PET in rationalizing long-term treatment following initial stabilization of irreversible disease requires exploration in larger cohorts. We need to have a database to quantify the therapeutic efficacy of glucocorticoids in patients with unacceptable loss of quality of life, to explore the efficacy and adverse effects of the use of low-dose glucocorticoid treatment, and to evaluate the optimal dose and duration driven by patient choice. Studies also need to focus on how high the initial dose of glucocorticoids should be, and how long should a patient stay on that dose, and how we got to taper those. Additional studies are required to evaluate the efficacy and cost efficiency of rituximab or CI, infliximab, biosimilars, and other immunosuppressive agents. Also, the role of antifibrotic agents such as nintedanib and pirfenidone needs to be studied further. And liver endpoints, including change in PET and quality of life, need to be updated. And this is also an important component of research on pulmonary sarcoidosis. This is a slide that I've taken from Michelle Sharp's talk on WUMIDI. She talks about the NIH funding of diseases of respiratory system. As you can see, the sarcoid is minimally funded in comparison to the other diseases that she looked at. I leave you all with this slide by Sahil that you are going to see in the coming issue of Lung India, where he has posed the questions, given the principles for handling those questions, and given suggested protocols for these patients. So, ladies and gentlemen, I leave you with this famous Robert Frost quote: "The woods are lovely, dark and deep, but I have promises to keep and miles to go before I sleep." I think it can't be more suited to any other disease and than to sarcoidosis. Thank you for your kind.
Thank you. We'll just make a quick check whether Dr. Parvaiz has joined us online for answering questions and queries.